Oh, I see. Okay.
Hi, Dan.
Yeah. Sure. Yeah, we'll make sure to mention that just so that doesn't.
It's a little abrupt at the end of the breakout. It just sucks you right back to the full room. So I apologize if you're mid-sentence. So let's just take a few minutes to recap what we just heard. We had a nice discussion in our room. The two questions were, what did you hear that was exciting or surprising? The second was, what can you adapt or offer that aligns with the priorities of the CDPH Chronic Disease Control Branch? I know we have a few responses in the chat that our team is reading, but anyone want to jump in and share an insight that they heard that they think the group would like to hear? Anybody? Unmute yourself. Yeah, please, go ahead. Who was that?
Rakshan.
Oh, Ramesh, please, go ahead. And Ramesh, please introduce yourself as well. We want to hear, know who's speaking.
My name is Ramesh, and I'm a pharmacist in charge and the director of ambulatory health program at Desert Hospital Outpatient Pharmacy in Palm Springs. I was just blown away at all the bold commitments that Dr. Ibarra had made, and this is, I mean, besides you, I think this is the next one that I've heard that actually is launching the pharmacy profession into a full-on CMM way. And which is what we've been training for, and we are excited that this opportunity is finally coming from the state of California itself. You know, her word is a state of California word, so I'm really excited about that, and that's what we exchange about in our group, how bold this one was.
Great, thank you. Very, very bold. I agree. Fantastic. Thank you very much, Ramesh. Anyone? Oh, Neil, go ahead, please.
As a retiree, and having spent 40 years in the profession, I still have a concern with all the things that I read about the chains. Are we working with the chains to change the culture, to allow for things such as this? It's really exciting to have someone who appears to be pretty young professionally in a position like Dr. Ibarra that is totally behind the project or behind the conversion to CMM, but it still has to get to the local level. So it still takes somebody from above trying to impact the culture with the physician that they're going to be open to this idea and embrace pharmacists who do it. I mean, I as you know, I've been trying to do this consulting business ever since I retired, and it's a difficult way to go to try and impact the physicians or get them to open their doors. And it depends on where you are as well, because where I live is a relatively conservative area. So it's a little more difficult.
Yeah. Neil, go ahead. I'm sorry.
No, go ahead. Go ahead.
No, I see that's an excellent point. Certainly something that I've lived in my career as well. Yeah, this is why the collaborative exists in the first place, right? The idea is to try to leverage people that have a like vision, that are bold, ready to make big commitments, and leverage that collective you know, brain power, influence, et cetera. You know, Dr. Nunes de Ibarra is remarkably connected and experienced, and you know, her bold leadership has, I will say, has single-handedly changed the mindset of CMA when it comes to pharmacists and CMM. I believe they even have adopted a declaration in support of it at this point. So there are just, I think that at the end of the day, we need multiple approaches to battling this problem. We're dealing with it in partnership with payers, working on the value-based side. Dr. Nunes de Ibarra is working from the states with the legislative side. We have just so many partners, Dr. Tony Kuo locally here in LA County. We even have some folks from the DER board here with us today that are actively working to influence. You heard covered California. You know, so I think we have to light, I hate to use the analogy, light fires from different points to try to, you know, get to our goal. And I see that happening more and more today than ever before. You know, the one quick insight I'll share that I see written that we talked about in our room is, you know, that sort of that linchpin that happens outside of your Kaiser and VA, that's sharing clinical information. And you heard Dr. Nunes de Ibarra commit to pushing that forward, getting HIE access to pharmacists so we can be a part of that healthcare team, sharing that information back and forth. What a game changer that'll be. So I think we're really in a good place in terms of direction, and we have the right people in the room. So thank you, Neil. That's a great challenge, and I think this collaborative is all about that challenge.
Steve,
yeah, go ahead, please.
This is Ndokako Melo. I work with Dr.
Yes.
Nunes.
Welcome. Thank
How
you.
are you guys doing today?
Good, good. Thanks for joining us.
So I was in a section, breakout session, and what I heard from the pharmacist in there is that they're interested in improving engagement, resource and network sharing. And I didn't have enough time to be able to dive into get specifics of the type of resources and networks. And that's what I would be discussing with Dr. Nunes later on, because every pharmacist or pharmacy location might have different unique patient population, and each of these have, you know, different needs, right? So what does that resources meant for each of the pharmacy location? What is the network resources around their demographic characteristics? So there's many things that we should consider as we move forward with rolling out CMM to many pharmacists in California. So like Wagner said, this is gonna be a long process. It's not just one glove fits all. We have to be thinking that way in order to achieve what we intended with implementing CMM across California.
Absolutely, well said. You can say that for every health plan, every pharmacy, every neighborhood. We've even spoken to other national collaborators doing similar work, and they've told us the same thing. They said, look, we understand that what we're doing out here in the Midwest and the East really doesn't necessarily work for California. We'd love to learn more from what you all are doing. So I would encourage us to stay in contact, learn from our networks. They're serving so many different types of populations. Let's create that best practice model for the different types of patients, very diverse patients we serve in California. Thank you, that's fantastic. Now, I believe we need to, I'm sorry, I would love to keep going because there's so much rich information here, but I think we need to move on to our next speaker. So I'm going to introduce someone who is familiar, I think, to many of you in LA County, and definitely those of you that have been in our previous learning sessions. Dr. Tony Kuo is Director of the Division of Chronic Disease and Injury Prevention, the LA County Department of Public Health, and Director of the Office of Senior Health for the County of Los Angeles. He's a professor at, I like to call it the community college across town, UCLA, with joint appointments at the David Geffen School of Medicine and Fielding School of Public Health. In his government and academic roles, he oversees a broad scope of work ranging from tobacco control policy development to health system change, and promotes increased access to clinical preventative services among low-income populations. He's got more than 15 years of practice and research experience. His body of work reflects his interest in the nexus between policy, research, community activation, and health and public health practice. He received his medical degree from University of Utah School of Medicine and a master's in health services from the UCLA Fielding School of Public Health. Board certified in family medicine and a fellow of the American Academy of Family Physicians. And just a remarkable leader in terms of his accomplishments, his ability to move mountains. I like to say that in working with Dr. Kuo, I have witnessed his ability to completely change processes, programs to be much more effective. And yet he's often behind the scenes, a remarkably humble leader who just has so much knowledge and ability in transforming the healthcare system. So we're going to hand this off to Dr. Tony Kuo, who's going to talk about resources in the county that can help us achieve our goals in CMM. Dr. Kuo.
Thank you. I'm going to, let's see, can everybody see my slides?
Yes, it is. Yes, it just came up.
All right, perfect. All right. So anyway, thank you, Steve. As you know, just like Dennis Wagner talked about the BOLD initiative, I recall at the beginning of this concept of the collaborator talking to Dr. Chen, and I was just struck by the tremendous vision he had of all these moving parts. And you think about it, I think how time had flied and how we're already in learning session 3, sort of 3 years into it. And I don't want to jump the gun, but the list he put up, he literally has provided tremendous leadership in moving almost every pieces to this point. So Dr. Chen and the group asked me to sort of talk about the LA County perspective, and I thought this is a great opportunity to really talk about how CMM as a proven framework could really function in terms of chronic disease management and prevention, even for LA County as we kind of move along, to think of it like this great opportunity that where value-based payment model is already being sort of piloted, and then hopefully over time can be sustained throughout. So just like everyone else, I have nothing to disclose and no conflict of interest in my presentation. I think, as I mentioned, what I wanted to talk about is sort of the state of LA County in terms of risk factor of cardiovascular disease, and why the collaborative and CMM actually can play a significant role as a key team care intervention in that respect. One is also kind of mention what, you know, as everybody's been talking about, what the LA County public health and also just in general the government infrastructure, what type of resources and programs that are there, what type of opportunities that this group and other groups that are interested in managing hypertension, diabetes, and some of these common chronic conditions can actually potentially leverage. So I'm going to start with a poll question. And I guess, Diane, would you be able to pull that up? So this is, which of the following is true regarding blood pressure management in LA County? So between 1999, 2006, 2007, 2014, blood pressure control has improved from 25 to 75%. American Heart Association's target BP for Americans is 70% by 2025. Comprehensive medication management has proven to be effective in multiple settings: clinical, community, urban, or rural, or D, all of the above. I guess I'll provide a few 30 seconds.
Yes. Can we run the poll? Muriel, do you have the poll question for this one?
I do not see the speech poll question.
Oh, okay.
Diane?
We did not
Sure.
convert. Okay, Tony, I think we may not have made this a poll question. My apologies.
Oh,
I think we
okay.
missed it. Sorry.
Well, that's okay.
We can have people type their responses in the chat, though.
Exactly.
We can get some responses.
Yeah, here we go. We're starting to get responses, Tony. A lot of Ds.
A lot of Ds.
All Ds.
All Ds.
So the rule of thumb, if you don't know, you guess C or D. No, that's not it, right? Yeah, 100% D, one C, but otherwise all Ds, it looks like. One or two.
All right.
Cents.
Well, that's actually a great guess, but it's actually not the answer. It's actually, the answer is C. CMM obviously is a proven framework. It have been implemented and tried in multiple settings with pretty good effects. The reason A, it sounds almost a very impressive gain, but it's actually only up to 50%. So even in LA County, even though this was based on an enhanced study not so long ago, and even though what they found was a lot of people are more aware and is on treatment for hypertension, but for some reason adherence probably is the sole reason. But at least half of the people that were surveyed still do not have blood pressure control. And then, of course, many of you may know the American Heart Association's target blood pressure is actually 75% by 2025. So anyway, I apologize for throwing some left curveballs in there. LA County, the reason LA County not only because I live in LA County and work for the LA County Department of Public Health, but Los Angeles County as a whole, it is a really important area, and part of it is it's very large. It's larger than 42 states. And for over 4,000 square miles. It's geopolitically complex, 88 cities, numbers of hospitals, numbers of health systems, more than 10 million residents, and literally 1 in every 4 Californian actually lives here. And we have a multitude of different groups, over 100 languages spoken. All that being said, LA County is important in the sense that whatever we can actually pilot here, oftentimes actually is scalable in other areas, and partly is because of the diversity, but also because it's so large, that and the system is so interconnected that, you know, you could really do some prototyping here that can be used to kind of inform intervention initiatives elsewhere. The one thing about LA County, though, that's interesting is that if you look at their life expectancy data, and this always have always struck me as very impressive in the sense that literally where you live actually could determine how long you live. Life expectancy disparities is quite pronounced. And you could see from this chart that you could, if you live in low income or under resource areas, your life expectancy is closer to 75 years. Whereas if you live in really affluent areas and you have access to resources and good care, you're looking at more like 90 years old on average. And then if you look at some of the data around chronic disease in LA County, you sort of see the same sort of spread as the life expectancy. This one is on coronary atherosclerosis or cardiovascular disease. And you could kind of see that the more densely shaded areas obviously falls in a lot of the lower income area or the rural area, right? SPA 1 up there, Lancaster, Palmdale, very high with cardiovascular disease. If you try to break it down by race and ethnic groups, you could see that heart disease, stroke, this is mortality data, #1 in Black men. And this of course is where public health and health services in the county have been trying to work to reduce. And both of these, as you know, has one common sort of common cause or a common risk factor, the most modifiable one, which is hypertension. Chronic disease prevalence, if you look at, again, high blood pressure is here, but if you also look at diabetes, obesity, and high cholesterol, these are all in a way, all related. And again, all potentially where CMM can make a tremendous difference. This one's broken down by male versus female. And then again, as I mentioned, the control, this was that enhanced study I had mentioned that inspired better awareness. Instead of more people being on treatment, our control is still only relatively 50%. So somewhere along the way, the system that is currently in place is not helping. Is not optimized to control blood pressure. And then let's not forget about health behaviors too. The other thing that from a public health perspective in LA County, we also think about cigarette smoking, secondhand smoke. And then of course for young kids now, you have a vaping epidemic. And if the addiction to nicotine it started early among youth, it's going to lead into adulthood, and then ultimately tobacco, whether it's e-cigarette or regular cigarettes, basically contributes to hypertension, diabetes, cardiovascular disease, all in the long term. So what is in some way the commitment or the work of public health, at least locally in LA County? We previously had a grant from CDC, this was of 2014 to 2018, which we started. This was when we actually started talking to Dr. Chen and this idea of the collaborative and the idea of how do we promote and integrate CMM into the health system of care. Well, we were lucky and actually was able to build off the next iteration of this grant from CDC, which they call 1817. You'll find CDC actually likes numbers, so 1422 to 1817. So we're kind of progressing. And what this initiative locally is called Solutions for Healthier Communities. And what we're committed to is using some of that funding to really work on the two strategies here. One is to sort of explore and test innovative ways to engage basically non-physician team members, pharmacists among them, CMM among them, with a focus on trying to improve hypertension and cholesterol management and control. Another is to really promote adoption. For CDC, it's just generally medication therapy management. But for us, we felt that at least in LA County and California, it really should be CMM, especially when we have the policy and the changes in the scope of work for pharmacists in the state. And as I mentioned, we're doing this through, provision of technical assistance. The bigger part is really support and engage in research and evaluation and data monitoring where we can. Working with leadership for sure, whether it's publicly or maybe in the background, which sometimes is the most important place to work in. And then, of course, as I mentioned, providing just direct funding and support, for things like developing tools and protocols. Some of our partners in this effort, obviously, USC School of Pharmacy. We're really excited to support this continued growth and development of the collaborative. We're also working with the Department of Health Services. They're really large, 4 hospitals, a number of ambulatory care clinic networks, and we're trying to scale and spread use of team care approach that tries to incorporate use of advanced practice pharmacists skills and protocols. And then, of course, with Cedars-Sinai, we've been trying to support them in taking that next step. They had under the late Dr. Ron Victor, they had done a really wonderful randomized control trial that demonstrated that you could do literally a variation of medication management through recruitment and through barbershops. And they were able to demonstrate really great findings. What we're hoping to do is to work with them on how do you actually transform a program that's built in a research setting to actually being able to scale in a community setting. All right, I'm gonna do, I take it I don't have a poll question on this.
I'm sorry,
either, right?
that was my fault. I should have, I forgot to do that.
Anyway, I'll read this and I am interested to see what people answer on this is. California law on licensed pharmacists' scope of practice made a critical shift in 2013 with the passing of Senate Bill 493. This bill allowed for all the following except A, pharmacists can independently initiate and administer certain medication and immunizations per state protocols without further training or certification. B, authorize an advanced practice pharmacist board recognition program. C, declare pharmacists to be healthcare providers who can provide services. Or D, none of the above. And I'll wait it for a few seconds.
A lot of different answers, Tony.
Would be interesting. So what's the most?
Boy, you might as well just go right through the list. They're hitting everything. Let's see. Yeah, lots of A's, right? I don't think there's even a consensus. You hit a controversial question here.
Well, perhaps a controversial bill, right?
Yeah.
So the answer is actually A. A is almost true, except for the part about not requiring further training and certification. And that, in a way, is why this CRMC is going to play such a critical role, right? Because eventually, I think Dr. Chen's and the group's vision for CRMC is to become sort of that certification arm. I mean, the training arm, so that you could prepare pharmacists for certification. B and C are actually true. I think that's sort of consistent or with the intent and spirit of SB 493. All right. So I want to leave you with this. So in terms of implementation, as I mentioned, the Department of Health Services, USC School of Pharmacy, Cedars-Sinai, this is sort of a grid we kind of came up with to sort of think of, what are some supportive factors that could really facilitate this work. And then, of course, the anticipated challenges. And as you can see, in a large health system, especially a safety net system like Department of Health Services, the supportive elements is that, sometimes when you have a government, a large infrastructure, you could get flexible fundings. It is potentially very useful to try to recruit physician and even pharmacist champions. And then, of course, building off existing efforts because it is such a large infrastructure. Of course, anticipated challenges is that it is a bureaucratic system, and sometimes things just takes a lot longer. And then also because of multiple competing priorities, which sometimes drowns efforts like this out. Same thing, you think about the barbershop, the success of the research project and the national recognition of this success offers a lot of momentum. But then you also have to think, but in terms of challenges, there is a fine line between a research project and actually being able to do it in the community, principally, especially with regard to the fact that most research projects are actually better or more well-funded than community transformation. And then, of course, USC School of Pharmacy, which is already doing a number of incredible things and innovations, including trying to scale telehealth. All of those really kind of help push CMM or can push CMM in health system integration. The obvious thing is the sustainable reimbursement model, the value-based model. How do you actually do it? And of course, depending on which system and which region, even as I mentioned, LA is so diverse and large, you do end up with multiple platforms and approaches. And then I want to show this map. This is basically pharmacy landscape. If you really look at pharmacy professionals by zip code and pharmacy retail stores by zip code, as you can see, it's pretty wide, comparable but very wide and broad distribution. Again, goes to Dr. Chen's thinking around this, that community pharmacies literally is like an established network that could be used to do better chronic disease, hypertension and other chronic disease prevention and control. And the other thing that I'm going to end with this, the one thing that is nice about CMM, not only are you hearing both federal and also state commitment, in the Western states, half of the organization that represents the American Heart Association, they have a chronic disease prevention and management committee, and they're actually advocating for this as well. They've been trying to initiate call to action around better implementation and scale of CMM because they really feel it is a nexus and synergy between pharmacy and public health and health services. And really, in some ways, this is unprecedented time to really scale this, especially if you consider COVID-19. And this is what I will end with. I know previous speaker have mentioned it, COVID-19. CMM could be a valuable solution to this just because we know that a lot of the chronic comorbidities are actually the strongest risk factors associated with mortality due to this infectious disease. And in a way, moving forward, chronic disease management or management of these comorbidities really should be one of the key tenets in the emergency response to this disease. So I'm open to question and answer, and thank you for the opportunity to talk about the LA County.
Tony, thanks so much. We are actually going to hold on Q&A.
Okay.
What we've been doing is posing some reflection questions and having our breakouts. Because we're running a little short on time, can we flash those questions really quickly that we have? I think, Tony, we need
Yes,
to, yes.
I'll share those.
Thank you.
Let me get out.
Thanks, Tony. And Tony, thank you for that overview. Always such an impressive array of data tracking and knowledge of the fine details of what's needed in LA County. We really appreciate your expertise and your leadership for the County of Los Angeles in chronic disease and so many other areas that you lead. The questions that we have are similar to what we posed before. What are your most valuable takeaways from Dr. Cole's presentation? And how can you leverage some of the resources he shared to improve health outcomes for your patient? But instead of breaking out, because we're running short on time, we thought if you can provide some responses in the chat, now that you've had a chance to sort of think a little bit more about what he just shared, please enter those. And for anyone that would like to share, we'll take 1 or 2 comments from Dr. Cole's presentation. Does anyone want to respond to either of these questions?
So this is Lori. I think it was interesting to show, like, you know, the maps as far as, you know, the differences between health outcomes based on areas that you live. I thought that was interesting.
Yeah.
And then just the fact that, you know, the different areas that he showed, like the barbershop project, USC's involvement and the DHS's involvement in trying to provide CMM. So I think that was good resources for us to look back on to help us with leverage and implementation of these programs.
Yeah. And by the way, Lori Mendoza is from Loma Linda University, part of our pilot team in CRMC. So thank you, Lori, for sharing that. Couldn't agree more. It's a bit shocking to see the vast diversity in health and mortality right across the county, and it tells us that we could, you know, make some tremendous gains trying to get to those areas with major disparities. Any other comments before we move on to our next? Okay, Eddie, were you going to say? I'm sorry, were you going to say?
Oh
something?
yeah.
Yeah, please go ahead.
For the leverage of the resources shared to improve health outcomes, I think this program itself, it has been really direct. My name's Eddie. I'm in charge of Vermont Pharmacy. I'm also part of the pilot program also. Through the learning sessions, our knowledge has increased so much where I've been able to, just in counseling, I can talk to patients and point out certain things that I used to not think about, especially with asthma, where a patient's taking their ProAir every month. I talk to them and have like just a 5-10 minute conversation with them, and we can make adjustments. And it's really been really helpful. So this is a great resource for just education as a pharmacist at a counseling point.
Thanks so much, Eddie. Really appreciate that. Okay, so we have a bunch of comments in. Please go ahead and take a look at those when you get a chance. I think what we'd like to do now is move on to have Connie Kang speak a little bit about some resources that we've been preparing for our teams. Connie is an assistant professor here at the USC School of Pharmacy. She previously was at KGI School of Pharmacy. We were able to still here just recently. Before that, she's had a career that just remarkable in terms of diversity. She's been in a broad variety of practice settings, hospital, community. She's board certified in pharmacotherapy, a certified geriatric specialist. She has a doctorate of education, just overqualified for anything that she does, and has done work not just for us with this collaborative and with LA Care, but also is leading our interprofessional education efforts, particularly with Kaiser Permanente School of Medicine. So Dr. Kang, would you like to talk a little about the resources that we have available or are developing?
Yes, thank you so much. So I'm going to try to be really quick and consolidate this to less than 5 minutes. If I can have share screen, please. And I have put into our chat the CDP portfolio document. If you would open that up as we talk, that would be really helpful in facilitating this conversation. So as you do that, I'll start framing for us what we're going to talk about. We're going to talk about basically what we've created and what we've created to basically be a manual of sorts. But I realize that we are not in the days of manual anymore. We check it all. So let me explain it like this. Basically what we're providing right now, and you will be receiving it with the slides, is our CRMC Practice Alignment Guide. So what does that mean? It contains many pages and appendices of how to navigate CRMC, but at the same time, we recognize that this needs to be a tailored approach. We're all coming from different pharmacy backgrounds in terms of, where you're at, what the workflow is, how big you are, who are the people involved, so many more. And therefore it needs to be tailored. The troubleshooting will be different. So with that said, I will just say it's basically going to help us and serve as a guide. I'm basically here to introduce that in just a few minutes, as well as focus for us on a portion of this that is part of the appendices, and that's what you see as a document that I've put into the chat box. So basically, I'm going to go over the overview of the guide. Next, I will go over the select resources that I've kind of said there in the appendices. So I'll kind of highlight those, not go into any depth, and also focus on, we're going to call it the CPD portfolio, the continuous professional development portfolio that we're going to use throughout today. Next slide, please. So starting with the overview, next, we are going to talk about, so what this guide does is talk about what is CRMC, why is it valuable for all the different stakeholders involved, and what's in it for each of the stakeholders. What are the CMM steps? As Eddie mentioned, we've gone through extensive training, and that included webinars, case discussions, journal clubs, etc., our pilot meetings, one-on-ones, coaching, and all of these were to emphasize the different steps of CMM. So you'll see that this guide will encapsulate it for those who have not gone through the training yet, so they can flip through these pages and get a sense of what CRMC is all about. How to basically, okay, so I'll move on. Next slide. In terms of the resources on there, it's very visual heavy, it's like a toolkit of sorts. So you'll see samples of workflows, explanation of workflows, and then it'll lead you into how to either make your own workflow or modify your workflow. And this is a constant. If you are in the stage of where you've already made a workflow, you're not going to modify it just once. You're going to modify it throughout. And you'll hear that today in the presentations. As people present on workflow, we're going to ask you to reflect on your own workflow. And that's how the last portion of this, where I'm going to introduce more about the document you see in the chat, how you're going to use that throughout the day. Next. Okay, so basically there are a lot of different tools. So this is a fishbone diagram. There are different, and we're just going to just show you real quick, okay, different rubrics, different tools. We're going to fast forward and say, okay, now on to the document. If you would just open with me the CPD document. As you do that, I'm going to explain the previous slide. So what is this all about? So the previous colorful slide will show you, and if you can focus with me what this model is trying to relate to us, it'll be best for us to start with reflect. So today you'll see that your document has a couple different pages, and it's really there for you to fill out, not just in a course of a day, that's not possible, but starting today, starting at lunchtime actually, and starting with 5-minute segments here and there, we're going to ask you to start by reflecting. At each point, once you, in the reflect step, you're going to see that it links via the red arrow to record and review. Next, you see the arrow taking us to planning. And then from the plan, you will learn, and all the while documenting on the various different pages, and then you will evaluate the learning. So we're doing so much learning today. This is an opportunity for us to reflect. Primarily during lunch, I'm going to ask you to please take a long while to work out that first page that you are able to fill out. The previous pages are more of an introduction. And then once we evaluate, you're constantly applying this, and it's really a PDSA cycle. It's really a plan, do, study, act cycle for your own professional development, and we'd love to have you all engage with it a very detailed way today. Next slide. So what you'll see is this document has a couple different sections: reflect section, plan section, evaluate, and a log. Again, I want to stress what the ask is today. The ask is that you try to do this as best you can. You can focus on more depth versus breadth is what my recommendation might be. But basically, you know, seeing what this is all about. How do I use this? What are the questions asking? And just, there's no like end goal, because it's really meant to be a long, continuous process of where you need to be by the end of today. However, the more you get done at lunchtime, the better positioned you will be in order to, in the 5-minute segments after certain sections that we have planned, you'll be able to target the learning and reflect on that and evaluate that learning that you just did within that section. I think that's the end of my slide, and hopefully that was somewhat clear. I know it's really fast.
Connie, thanks so much for being as concise as you were. I know that we're running a little behind. So we're going to ask you all to take, we had a 10-minute break schedule. We're going to make it 7. I hope that's enough time for you all to go to the bathroom and do what you need to. And we will reconvene at 11:20. See you guys in 7 minutes.
Hello, I'm here.
Alex, is that you? All right.
Yes,
Okay,
I'm here.
awesome. Alex, we're going to do
And you can see my video. Look,
yes.
This,
Oh.
look at you. Do you like this virtual background of a golf cart? It's virtual.
It looks like you're on a golf course. That's amazing. Okay.
Yeah, it's so real, right?
Yeah.
It just looks so real.
Now, if a golf ball hits you, then it gives it away. Okay.
Yeah. This virtual background's awesome. You know, you can pick anything: golf cart, golf course,
yeah.
beach in Hawaii.
Love it. Love it.
Hey, Steve,
so,
Alex, this is
hey,
Ed.
Hey, Ed, how are you?
Just want to make sure you know I was here
I know
too.
people have been asking about the slides, so I'll send it in chat again because I know many of you are back on, but we will be sending those slides out afterwards within a week. So please expect an email from the continuing education office by next Friday regarding the slides. And it'll also be available on the CRMC website too, but we'll provide that information.
Great. And then during the presentation, will you be able to show the slides, Diane?
Yes. So Dan, you'll be advancing,
yes,
right? Okay.
Yes. So for many of the speakers this afternoon, I'll be sharing slides on my end. Yes.
Very good.
The slides themselves are being shared with you either by the speaker or by myself